Well, thank you very much to all the speakers in the second session who've taken us on from just a description of what we're collecting in NICOR to start to talk about the way in which we can analyze the data in a more sophisticated way and importantly communicate it to our different stakeholders to close the loop from data collection but to deliver genuine quality improvement and quality assurance. And I think these talks have come nicely together and set us up for, I hope, will be an interesting discussion. Now, there have been a number of questions submitted around data submission, around data analytics, and also around the potential use of the data. But I'd want to start with some general questions to the whole group on the issue of participation in national data and data submission. One of the questions is around whether or not we ought to be thinking about consenting patients to participate in NICOR. The question was, are NICOR considering following the lead of SNAP, the Sentinel Stroke National Audit Programme, and introducing a formal patient consent? And is that something we want to do? And is that feasible in our data sets? And then what are we going to do when opt-out begins to become an increasing issue in the next year or so in terms of use of national data and making sure that it is representative? So perhaps I can ask Mark de Belder to start on a couple of those questions. Mark, what do you think?
Well, if I take consent first, John, this has been something that we discuss on an annual basis with our commissioners and also internally. The congenital audit within NICOR actually does work on the basis of consent, but all the other audits are collecting the information through what we call the S251 exemption, which allows us to collect data for the national purpose without patient consent. And it is extremely important from our perspective because we're dealing with two disease data sets, heart attacks and heart failure in particular, where you have some incredibly sick people coming into hospital. And to try and get consent on patients who have the worst outcomes, where we're looking to see the quality of care applied across the board, but particularly to the sickest, would actually almost certainly inhibit the national audit. So we have this discussion on an annual basis. There are some who argue that actually consent, we would still get a spectrum of disease, including the very sickest, but we are worried that there would be a disproportionate removal of potentially the most important patients that we're actually reviewing the quality of care for. As regards the data opt-out, it's unfortunately increased over the last few years. It used to be around about 2% of the population who are registered with a GP. It's now increased up to about 5%. However, we can remind ourselves that people can opt back in again. And actually for specific trials, patients who may want to not participate or not have their data used for the generalities of national audit and research may very happily be able to consent to specific trials, in which case they consented in for the purposes of that trial. So these are moving targets, but I think it comes back to the point you made previously that it's incredibly important, and we should also listen to our patient groups who agree that actually the uses of the national audit data, the national registry data, particularly linked with ONS and HES data and other data sets, has such value from a national perspective that we should encourage patients that there is more good than harm here.
Does anyone else have any views about the way in which we might do that, or make sure that we don't get the selected biased data sets that are potentially the threat of if opt-out increases?
John, could I come in here? I think that if the percentage of people opting out does increase, then at the very least we ought to be researching and studying the characteristics of those patients to see whether there is a particular systematic bias that predicts who is going to withdraw and what that means to our interpretation of care generally, not just characteristics of patients, but even geographical variation, and whether there is something that then becomes insidious within the national cardiac audits based on geographic differences in opting out. So I've got no answers, but if it does snowball, then I think we have to try and understand it more clearly.
I fully agree, and perhaps it's one of the areas in which we need to look a little bit more carefully at ethnic participation, socioeconomic as well, because as we all know, levelling up is top of the agenda for the government in terms of healthcare provision. It's now being increasingly looked at in terms of primary care, but also in secondary care and improvements in quality of delivery of specialised services. It also has, it's also very important. So that's something I think we're going to have to do more in the future. In terms of questions here, data completeness is something that has been asked a couple of times from our audience. Somebody's written, data completeness looks great and the tool looks great. Is it currently available on the various audits? And if not, when will it be available? Perhaps that's to you, Peter.
I think it, to be honest, I don't know. I thought it had been rolled out to every audit, but I'm not up to date with the last couple of months or so of development work. Certainly the aim is that it will be available for every single audit. Mark, do you know where we're at with it at the moment?
Although we still have one domain yet to go live for the entirety of the data tools, actually the data quality tool is available for all of the 6 major domains of the audit program.
Okay.
Mark, someone asked if it was possible to get data completeness by operator.
Of course, internally, the data completeness tool is available internally. Peter may have to ask you if you can actually set up an internal query to do it by operator, but it's not set up nationally to look at this by individual operator. But
no, I don't think that is possible at the moment, and that would require different sort of programming. So it's probably not going to be available anytime soon either.
So that's helpful. What about questions around BSIS and MINAP and the overlap between the patients in those 2 registries and in the reporting? Why are there still differences in the fields that are used in those 2 registries? And are they ever going to be merged? And what can we do to make sure that the standards and the questions we ask in the 2 are easy to translate from one to the other? So perhaps that's to Clive or Peter. Maybe you, Peter, to
I could perhaps start. It's been a long-term aim to try and put these 2 audits together in an appropriate association. And actually, we've gone quite a long way towards doing that now, because as part of a European drive, the Euro Heart Registry, we have now created and agreed data sets both for acute coronary syndromes and for percutaneous coronary intervention, and the 2 interdigitate beautifully. So it is our long-term aim to do this. That will require a change in both those 2 data sets, and therefore a change in the data collection tool for both those data sets and all the programming that you've seen that hangs off those data sets. So it's a lot of work, but it's definitely our ambition to tidy things up. I'm hoping that over the next 2 to 3 years we'll begin to do that. I'm sure if I could have some comments about that.
Yeah, sorry to cut across. Just to say that I'm hopeful that in the forthcoming year, that a domain report that was purely MINAP might become a very much a heart attack report. And with Peter's permission and collaboration, I might be able to include in that report the usual MINAP stuff, but some very specific PCI stuff as it pertains to heart attack. Remember that the reason that there's been this difference is that MINAP has looked on itself over the years as a condition-specific audit. You're admitted to hospital and a final diagnosis of myocardial infarction. And the BSIS, as was the BSIS audit, has largely been a procedurally driven audit. And that's the reason not every heart attack patient gets that particular procedure. And if you can think, therefore, of Venn diagrams, there are a large proportion of our patients that are common to both, but equally outside the overlapping of the two circles, there are groups of people who are separate. It's a difficult dilemma, John.
But the point is that the data collection burden is inappropriately great where there is duplication, and that's what we want to sort out. Clive's absolutely right. We're going to try and create a much more cohesive report. But my aim is that the data collection processes will also be linked in such a way that you only have to put a call time in one audit and a balloon time in one audit, and will produce a report and analyses appropriate to that.
So that feeds into this specific question of CTB and DTB being both reported in BSIS and MINAP, and are they ever going to be merged, and which one should be used as they're filled in by different people? That's for Peter. But they're often managed in different hospitals for the same condition and the same patients as they become old. How can we bring this together optimally to make sure we're not complicating things and missing a trick?
Yes, so I think the reason, one of the important findings with increase in the ACHD population is quite obvious in the sense that a lot of our patients are now surviving to that point where an intervention or procedure is required as they're moving to the adult population, and that sort of reflects. On the other hand, some of the complex procedures that we've been doing in pediatrics have been a bit more consolidated in a way that sometimes you require less number of procedures in the overall journey of a congenital heart disease, and probably that's reflecting. So I think the case mix and the complexity of the case mix is changing, and that is probably reflected in the last 5 to 10 years, and that explains it. I think one of the important aspects of making sure we can bring this together in a more cohesive manner would be to make sure that these patients get followed up and are not lost to follow-up. So I think one of the things that probably we've seen in the ACHD is there's loss to follow, and then they're picked up in adult cardiology at a different point in time, and then they are seen. So I think we need systems which will allow us to have that smooth transition, and they don't get lost to follow-up, and that probably would be the first step in trying to bring this together.
Perfect. Thank you. A special question for the surgical data for Andrew. Andrew, there's been a lot of discussion about reporting individual practitioners' data, and now a lot of emphasis on the team within which that individual works. What's your view on the best way of reporting quality outcome for centres? Should it be the centre, the individual, both? On how can we merge those reports?
Thanks. I think we've been having a bit of a problem with my link, so I hope you can hear me clearly.
We can.
Yeah. So the issue, I think that the feeling amongst the surgical community is that the pressure has very much been on the surgeons since going back now for about 15 years. It's very much surgeon-specific data that has been concentrated on, and actually it's really quite unusual for a surgeon to be an outlier. And so the mortality in the UK has become really very low for most sort of routine procedures. So elective, isolated, sort of average procedures, it's well up 1% both. So it's not a very good quality measure looking at something so bad. So the move and the wish of the surgeons, and I think everybody involved in these audits, is that we move much towards looking at the quality of process, so like speed of access, whether you have a pre-operative assessment, where you then need to discussion what input there has been to your approach to operation safety, which we do the wet operation, rather than purely looking at and to do that, you do need to look at those processes very much unit based. They're not surgeon individual. A lot of those processes. So it's the concentration, the desire of the surgical audit is very much to move towards different measures and other things. Just purely computation.
Thank you, Andrew. That was a great answer with a difficult microphone issue. Could everyone hear Andrew? I think what you're saying is we need different metrics, Andrew, for different things. We need individual surgeons, and the public want to know that as well, but the performance of the unit and is much more complicated than just an individual surgeon's performance, and I think that's the same for operators in the cath lab as well, and that we need to be much more sophisticated in how we collect those data and how we analyse and report them, and perhaps unit reporting will have an increase in importance.
We're still measuring surgeon outcome data, and we're still going to put that back to the unit. But it's obviously complicated due to big changes into surgery. Must still look at it.
So there's a question here about the follow-through on the data. There were fantastic talks on what we're doing in each individual domain in terms of collecting and analysing the data, but Dominic challenged us really to see how we can actually change practice with those data and what the process ought to be. Now, that was a fantastic presentation, but the question is, how do we democratize that? How do we get that out into the community when the places don't have the expertise and the team that you have, Dominic, in UCL Partners? What's the best way to close the loop, if you like, in terms of the collection of data and the analysis, and then making sure it makes the biggest impact on clinical care?
Well, hello, good afternoon, everyone. Thank you. I'm glad my presentation went well. I've had a number of people reaching out while I wasn't online, so I'm glad it was broadcast and received well. I hope I didn't give the impression that the expertise all sits in UCL Partners, because there are a huge number of organisations who have developed quality improvement expertise amongst their clinicians and managerial staff, and indeed patients now coming on board and developing QI skills. And I guess the overarching message for me really was that you need to start simple and follow a process. So I think people coming together to decide, well, what really needs to be improved and then how they're going to get there doesn't just require quality improvement skills. They help you to devise a plan and have a systematic approach, but actually it's about engagement, particularly clinical engagement, and wanting to do things different and better. And so I hope it didn't sound like that all needs to sit with UCLP, but it absolutely doesn't. But I know for you and a number of other national audits that they're looking at how do we engage clinicians in this data and in the agenda of doing quality improvement, so the audits actually lead to changes, not just keep measuring. There's a kind of proverb about if you measure something, it's not necessarily going to get thinner or change. And I mean, I tell my husband that often when I stand on the weighing scales. But if we just keep measuring things in and of themselves, it's helpful and useful to do, but improvement won't happen on its own. So I guess it's about working, audit teams working with their local clinicians and managers to think about how they do implement change, and it does take people to need to engage in the agenda. Organisations like UCL Partners provide lots of free online training for people that want to develop more quality improvement skills, so there's lots of things we can support with developing skills and capability as well. So I'm not sure if that answers the question entirely there, John, but hopefully people feel like that there is a space in which they can contribute to this agenda. It shouldn't feel like sideline activity that only people who are specifically trained in improvement can do.
It does answer it, and thank you. I think this has become one of the big developments in the program, in the sense that we used to think about the end game being collecting and collating the data, but now quite clearly we're challenged to make something happen in the community, and UCL Partners has really been a catalyst for that change in thinking. But of course it needs to be exported out, and the ability to teach and train people to do this is really helpful, both locally and nationally. And thank you for everything that UCL Partners does for us. I'm going to go back to a couple of specific questions that have come in, and they're often related to the sort of process of the acute patients who are included. This one says, we're a PCI centre who accept patients from non-PCI centres for angiography query proceed, and it can take days for the non-PCI centre to refer to us, and then days to get them to the PCI centre, giving us no chance of achieving the 72-hour target. Is there any plan to add a reason for the delay to the BSIS data, as not all these patients get a MyNAP completed by the PCI centre as they go back to the non-PCI centre for discharge and follow-up. So that's really, I guess, should go to Peter to answer that one.
Yeah, I mean, it's a very good question. Of course, the patient is at the heart of this, and whether you arrive at a PCI centre or another centre, the bottom line is you're ill, you've come to a hospital, and you should be treated within 3 days. And that often requires a number of different agencies and a number of different centres to collaborate in trying to make the pathways better and to try to use the sort of the UCLP tools that you've heard. So the specific answer to your question is the plans to change the data set are related to what I was saying before, which is we're trying to make the PCI and acute coronary syndrome data set aligned to the EuroHeart data definitions. There will be a change to the data set, but changing the data set is a huge thing to do, and we certainly would need to consider adding other items to a data set. However, what I would say is that, in my view, it's enough for us to identify for you that your patients are waiting too long before they come out of the hospital. And in a way, having identified it, we aren't going to be able to provide on a national basis the tools to allow you to unpick the different problems that you might need to try and solve to improve that pathway. And so I would turn the question back to you and say you should be collaborating with the centres that are sending you patients and with your own centre for trying to treat these patients as quickly as possible, having had it identified as a problem. So you have identified a problem, and in a way that's our role. Your role is now to say, okay, let's have a look and get some engagement with the stakeholders, ask the questions, make them smart, do a PDS cycle and try and measure it. And then we'll tell you if you're succeeding or not.
So that leads into a question here that says, is there a standardized method to secure funding for local audit and QI support? I found it very difficult in my current trust to get funding to employ an audit nurse or administrator for this important work. I guess that feeds on from your comments there that this is obviously important to be done locally as well. Any suggestions?
John, can I just say that it almost falls into what Peter was just saying. Locally in West Wales, we are beyond embarrassed by how awful our service has become post-pandemic in terms of transferring patients between District General and PCI Centre. Some of the so-called recovery money is going into pathway redesign, equaling quality improvement work. And I think we just have, as clinicians and people interested in the care of our patients, just to be magpie-like, looking everywhere and anywhere for where the money is. So you rob the bank because that's where the money is. So find out where the funds are going at the moment and try and get hold of some of it. Sounds very easy, but it's difficult. But I think if one waits for someone to come along and say, why haven't you bid for this quality improvement work, you'll probably wait a long time.
So that leads into my next question, is that we are in extraordinary times now with the pandemic and the recovery agenda, and there is a huge national agenda to deal with the waiting lists that have accumulated and the processes that we need to now get through in terms of resilience. I'd love to ask everyone from their domain what they think is the most important thing that needs to happen in the next year and the most important role for NICOR in trying to promote that in critical agenda and really improve the restoration of clinical care back to what it was pre-pandemic. So maybe we could start with you, Mark, as the sort of overall lead for the programme in terms of joining up the various audits. What should we be doing now that's most important over the next year, and what should we be measuring and reporting?
Well, it will be much easier for the individual clinical leads at the clinical coalface to answer some of those questions, but just standing back a little bit about it and listening to one or two facets that have emerged, one or two things quite clearly to pick up. For example, national initiatives for delays to treatment time. This is now, we have pretty good evidence over a number of years that this is a continuing and ongoing and actually worsening problem, and almost certainly I suspect things are going to get worse before they get better when we start reviewing what's happened over the pandemic year. But this is where service design redesign is so important, because ultimately, and we're sorry to hark back to a lot of things, but if patients, for example, with a heart attack or a suspected heart attack are still being taken to, in inverted commas, the wrong hospital, you are always going to have these delays because the inter-hospital transfer delays. And of course, if you take a patient, and London has done this as an exemplar, if you take a patient to a heart attack centre, even if they don't have a STEMI, but they have a suspected heart attack, then actually all of these in-hospital delays start to melt away. Actually, the number of ambulance journeys is reduced, so that takes some of the pressure off the ambulance services to do other things. So there's a knock-on effect that things get better for patients, but they're more efficient and they're just more effective. So I don't think that we should be frightened about service redesign, because I think it will improve things across the board. Other talkers, speakers, will be more able to elucidate that in their own domains. But that's really the main issue I wanted to say, that service redesign is something we should embrace.
So, Teresa, what about heart failure? What are the key issues for the next year in terms of an improvement in our measurements and analysis and reporting?
Well, I think the most important thing is, first of all, is going to be seeing what the data looks like in the pandemic year. If it's anything like smaller audits we've had from individual centres, we're going to get quite a shock, because we're going to see, I think, an increase in mortality for heart failure, a decrease in all the quality improvement metrics that we've been seeing over the last year. So I think we're going to have to see what the data looks like, see where it's got worse, and see maybe what's gone, hopefully maybe also some things that have gone well, and what centres have managed to, you know, keep quality care going during the pandemic, and then maybe drill down a little bit more on the data and see, well, what has good practice looked like, and how can that be improved in the future. In terms of I'd just like to cut in on one other thing about using pots of money for audit. Several of these audits are linked in with the best practice tariff. In particular, that the heart failure audit has two metrics: participation in the audit and specialist care, that give you an uplift on the reimbursement your hospital gets for admissions with heart failure, and that can be redirected towards audit efforts as well.
Fantastic. Francis, what about you? In your areas, crystal balls.
Well, I would agree with Teresa that we need to see what the data shows before we can draw any conclusions. But there's a very clear prediction that we have that volumes for the non-emergency electrical procedures will have dropped dramatically. In my hospital, they've dropped by more than half. And that will have an impact on competency of operators, and particularly on that of trainees. As you saw in my presentation, those bits that you managed to see, there's a large tail at the left-hand side of people who are not doing sufficient procedures to meet the non-national standard, and that does give rise to concerns for competency. And trainees in particular, I think I'd like to make a special extra little section on the impact on training. And I don't know how we recover that, because there's a steady mill of trainees going through the system.
It's likely to be a generic problem across all the domains, isn't it?
Well, I think, for example, angioplasty has probably been hit less because these are immediately life-saving procedures, and they were therefore prioritised.
Will affect surgery, they won't it, Andrew?
Yes, hopefully you can hear me now, but
yeah.
As the other speakers have said, I mean, we've only just got the data. We're talking about 2020, just data from 2021, so it's going to be very interesting to see what the trends are. Our initial assessment does seem to be quite a significant drop in patients being operated on, maybe by about a third of the UK. There's been a very wide variation between some trusts which have been really hit very hard and other places which have managed to keep going to 70-80%. So I think a lot of the metrics, like we were pushing the things from the GIRF report a couple of years ago, preoperative assessment, that's all gone totally out of the window with people not being seen preoperatively and a lot of phone consultation. So interested to see how that gets rebuilt. That being totally destroyed in the last. And as the final thing, as Francis has said, training, we haven't looked at it yet, but I'd be very interested to see how hard hit the trainees have been. I think some of the trainees have been very bad, had a very poor opportunities to operate in the past. Very keen to see what has been in their training.
So, Clive, even in a stable year, there are things that are happening in the MINAP field. But in this era when acute presentations went down 50% or more and recovery back to normal, doesn't that give us an opportunity to really analyse the impact of this pathway that we normally have and where we could really make a difference in the way that Dominic was saying? We could have a very clear process that actually joined all this up.
Sure. And, an early snapshot suggests that during the earlier phases of lockdown, where many hospitals were emptied of patients into care homes, etc., I think we'll see that the proportion of patients getting their angiogram within 72 hours actually went up. And that may reflect increased capacity at that time and slicker turnaround times. I suspect that towards the latter end of lockdown, when hospitals were trying and are trying to do all things to all people, we're going to see quite the opposite, and that areas that had been put aside for cardiology and cardiac patients are probably being used for other purposes, and I fear things are slowing down again. Mark, in discussions, has been interested in looking at an almost a month-by-month analysis to try, as you say, John, to understand what it is that has happened to us and whether that might then inform pathways for the future. Locally, again, anecdotally, we have patients who have stabilised within 7 days of their admission with non-ST elevation heart attacks, not getting into a PCI centre. And what do we do with those patients who are now apparently stable, apparently well? Do they go for a CT coronary angiogram? It's not in the guideline, it's not in the normal pathway, but pragmatically it's being done in 1 or 2 centres locally. What does that mean? So there are opportunities to observe and develop, as you say. John, can I also say that we do need to remember that the staff working in all of these areas have been under a lot of stress. What we never measure, but is very important, is kindness, reassuring patients, compassion, and so forth. Just because we can't measure it doesn't mean it's not extremely important. And we've got to try and be as forgiving of our colleagues as we possibly can. Sorry, just a bugbear of mine.
So, Kelly, from the patient's perspective, how do you think they see this recovery year for the health service, and what can we do to reassure them, support them in this difficult time?
I definitely think they see it as critical. That I've heard from a number of patients who've had quite difficult experiences from finding support, their routine support plus extra either medical support or psychological support to get through this period. Obviously, for a lot of them, they've had their lives quite restricted because they're clinically vulnerable, and yes, I think they see it. What happens next is absolutely critical to their well-being, and we ideally need to reflect that in the next patient report that we publish next spring. and maybe look at the future on talking about the means of support that are available.
So I've got one last question to the panel. How could we make heat maps of good and bad practice for heart failure and MI evidence-based treatments? So this is making a map of good and bad, but also I suspect value as well could be added onto that. Teresa, pick that one up?
Yeah, I mean, I think that's a great idea, because also it picks up on something else that's certainly not in the heart failure audit just now, which is regional variation and mapping to inequality. So I think it would be quite easy to do from the new data visualization tools that we've seen, and it would be something, I wonder whether it's maybe not the right thing to do in the COVID year of data, because a lot of our specialist nurses who put in the data were redeployed. But certainly I think for the future that would be an excellent way to go forward.
If I can explain, we are in the process, in fact, we've virtually finished creating a mapping tool, which was one of its roles is to look at rates per million population in different regions around the UK. And we can feed any data we like into that tool. So we can look at TAVI rates per million, we can look at surgical rates per million, we can look at beta blocker prescriptions for heart failure per million. And so we will be able to create those visualizations. And I think they will be very valuable. I think we will see regional variation, and it will allow people to focus where things are missing. Those tools should be available very soon. And I think a very exciting development in the way NICOR presents data to its audiences.
And just to add to that, Peter, we're also behind the scenes, we're working on a new way of presenting the range of metrics that we're measuring in the different domains at a hospital level, and they may well become available at a commissioner level as well, but to a hospital level to look at a range of performances. So actually there'll be a much rather sort of each hospital going through the tables to try and find out where they are and, in the mix. We'll find a new way of presenting data that makes it much easier for that particular hospital to see where they stand in terms of their performance against their peer groups.
Thanks, Mark.